Jeremy Albright is our next presenter. Jeremy has been the statistician for vascular surgery and MISIC for many years now. And now he's going to talk about risk adjustment methodology. Jeremy, the floor is yours.
Thanks, Rebecca, and thanks for inviting me to talk. So I'm going to go over the methodology behind the risk-adjusted results that you get, especially in the three-year reports. Some of the information that we present is a little more self-explanatory than other information, so I'm going to go over as much as I can to help you interpret what you're seeing and get a sense as to where we come up with those numbers. Essentially, what we want to do is provide a consortium-wide summary of hospital performance, so you can compare yourself to your peers. You can see where your peers stand in terms of meeting the different goals that are laid out. The challenge, of course, is that every hospital is a little bit different. There are different volumes and there are different mixes of patients. Some cases are more complicated than others, and the mix of patients can vary widely between different sites. So I'm going to pick out a specific example, and it's going to be transfusion rates, and walk through the steps of performing risk adjustment and what the graphs are that we present to you and how to interpret those. So I'm starting out with just this example. This is 30-day transfusion rates, and it's not exactly the same data that we've reported in reports. It's pulled from a different period somewhat, but it'll give you a sense as to what's going on. So this is just the raw presentation of rates, the percentage of patients who undergo a transfusion within 30 days of the procedure. And you can see just by looking at this figure that there's wide variability, but what this figure isn't going to be telling you is what's going on within the specific hospitals, what the volume is and what the patient mix is. And to give you a sense as to just how much hospitals can vary, this slide here, I've added on the volume. This is the number of patients seen in the period that I pulled who either experience or do not experience a transfusion. This is essentially the denominator when we calculate the proportion or the percentage. And again, you can see very different numbers, and these numbers don't really correspond to the transfusion rate at all. We have one hospital down at the bottom that has very low rates, but an N of 114. And then if you go over to the right, there's this one hospital here that I think is going to be kind of interesting to follow. The volume is only 4 for this period that I pulled. And we're seeing that it has really generally a high rate at about 50%. Well, with 4, then you only need 2 patients to get you to 50%. So this is kind of an unfair summary of how the site is actually performing. And it actually even gets a little bit more complicated. So this next slide is the same information. It's the same rank ordering, but I've color-coded the bars in terms of the average number of comorbidities that a patient has when they present at this particular site. And this poor site right here not only has a low volume, but it also has the most complicated patients that are being seen. And because it's darker red, that means that the mean number of comorbidities is up towards 12 for the 4 patients that were seen here. So not only does this hospital have a low volume, it has, when it does see these patients, some of the more complicated patients. So it's not particularly fair to say that this is the 3rd worst performing site in the entire system. So we want to find a way that we can present this information in a somewhat more fair manner. So the steps that we take as the statisticians when we're given this data, you can think of it as 4 steps that follow each other. The first is that we take the patient level data for all the hospitals and we fit a statistical model to predict the probability of an event, in this case, transfusion. What I mean by statistical model is essentially we come up with a formula that takes all of the potential risk factors, demographics, comorbidities, any health histories that we think might be relevant, and we weight those differently because some will be more important than others, and ultimately come up with a formula that we can plug in patient level information and come out with prediction, a predicted probability of experiencing the event that we're talking about. That probability, it's a probability, so it ranges from 0, meaning it's not going to happen, to 1, meaning that it will happen. The closer to 1, the higher risk the patient is. So we take that model and that formula and we apply it to every single patient, and every single patient then is assigned a probability of experiencing the event. Whether they did or not, we have a probability of that we would sort of a level of concern that we would have for the patient. Once we have all of these probabilities for all the patients, we then actually use it and aggregate it to the hospital level to form what's called an OE ratio. The ratio is the observed rate versus the rate that we would expect at that hospital, the percentage of people experiencing the event at the hospital, given the patient mix that they're seeing. And then the fourth step, when we want to get a risk-adjusted rate, so not the raw rate, the observed rate, but what we a rate that takes into account the patient mix and the volume, we first calculate the overall rate across all hospitals and then simply multiply that by the OE ratio, and that gives us the adjusted rates. Now, there's a lot going on here, and so it might be, in one slide, a lot to take in, and sometimes people get a little bit intimidated when they hear words like statistical model, probability, or any type of formula. So we're going to do this step by step, and hopefully that's going to help it make a little bit more sense. So the first step is we fit that statistical model. And when we fit a model, we as the statisticians get this output that we interpret. We don't give this to you because this would be kind of overwhelming. We don't expect you to interpret it, but this is what we're seeing. So I said that this formula has different weights for the different risk factors. And those weights they're related to, they're not exactly the same as what I have here as an odds ratio, but they're very closely related. And that odds ratio tells us which of these risk factors is playing the larger role. It's sort of an effect size. If we change somebody from a non-smoker to a smoker, how much does their risk change? But whenever we calculate these numbers, we have a sample, there's always some uncertainty in it. So we differentiate between effect sizes that we think are statistically significant versus not. And when it's statistically significant, that means, well, we're pretty certain that this effect, it may not be exactly what this number says, but we know that it's non-negligible. It's different than zero. So the p-value in the final column, those intermediate columns, you don't have to worry about it at all, but they're essentially numbers that go in to help us get a p-value. And that p-value we look at and use it to determine, is this non-negligible or not? Is this significant or is it not? And the convention is if that p-value is less than 0.05, we say, well, yes, it's statistically significant. Again, this is a lot of information. We don't want you to have to sit and stare at this table and struggle to make sense of it. So we present a simplified form. We say, okay, we ran this model, and these are the terms that came out as significant, as having more than, or having a non-negligible effect on predicting the outcome, the event that happens. So you can just kind of get a sense as to what came out of the model, what the model is saying are the biggest risk factors when you look at this. And some things they're generally not too surprising. Racial minorities tend to have a higher risk. Smokers, people who are anemic, who have more comorbidities, tend to be at higher risk. If it's an emergent as opposed to an elective case, or an urgent case as opposed to an elective case, that matters as well. So this kind of just tells you what seem to be the most important factors that are predicting the outcome that we're talking about, in this case, transfusion. So we give you this information, but then we take another intermediate step that we don't necessarily show you, and that is we go back to this patient level data and we give each patient that probability, that risk probability. And so this is fake data, this isn't the real data I was looking at, but this is fake data just to give you a sense as to what that looks like. So within this hospital, we're just going to call it hospital A, we have 10 patients. That transfusion column, it's a 1 if they had a transfusion, it's a 0 otherwise. And that probability comes out of that model, and that probability, the closer it is to 1, the more likely it is that somebody has a transfusion. You can see that those with the higher probabilities tend to have transfusions. There's some exceptions because it's a probability, it's not a certainty. So we have one case with a high probability that still nonetheless did not have a transfusion. That's how probability works. But what this helps us do is give us a sense as to what the overall risk would have been. We then take this information and by hospital, and then we add up all of the transfusion column, and that gives us the observed number of transfusion at the hospital. That's what actually happened. That's what we were seeing in that very first group of slides that I showed you. But then we can add up those probabilities, and adding up those probabilities gives what we would expect to see given the mix of patients that this hospital is seeing, given the complexity of the typical patient that comes into that site. So we have an observed value, we have an expected value. And so we can use those, plug them in to get this OE ratio. The OE ratio then in this specific example, imaginary hospital, we take that observed value of 3 divided by 5.4, the expected number, and that gives us this OE ratio of 0.555. If you have an OE ratio that's less than 1, that's great. That means that you have had fewer transfusions at your site than would have been expected given your patient mix. And then likewise, if you have an OE ratio greater than 1, that would indicate that your hospital has more transfusions than we would expect given the patient mix. So we can calculate this value for every single hospital, and then we present it to you in a chart that looks something like this. The OE ratio that we calculate is the dots in these figures as we read from left to right. We have these dots, and then we have these what are called error bars that represent the confidence intervals. So the OE ratios are great. They account for the patient risk, but these confidence intervals are really important because they're also related to the patient volume that you're seeing. When you see more patients, then that means we have a lot more certainty in how your site is performing. And so those confidence intervals, they're going to be a lot smaller. There's less uncertainty about that OE ratio that we've calculated. But if your site has fewer patients, then we're going to end up generating a really wide confidence interval, because even though we have a value for you, there's just too little information that we have from your site in order for us to confidently say if you're doing better or worse than the rest of the hospitals in the consortium. So when you look at this slide right here, it's important to consider both things. First off, do you fall above or below this value of 1? A 1 means that you are average, you're typical. And a value below it, a dot below it, would mean you're doing better than average. And then a dot above that line means you're doing worse. But you may be doing worse, yet you have a smaller number of cases. You're that site that just had 4 cases, and you only needed 2 then to look like you're not doing very well. But because there's so few cases, we're very uncertain. So what we do then is include these confidence intervals, and we say you should really only be concerned if you're above the line and the confidence interval is above the line as well. For any of these sites to the right, except for the very last 3, that confidence interval crosses 1. So these sites are doing, essentially the OE ratio suggests that they have a higher rate than they should have of transfusion, but it's the data aren't clear enough for us to say we should be concerned. But meanwhile, the sites on the right, those are sites that we might want to talk to in greater detail. Say, you know, what's going on at your site? We're concerned about the higher rates of transfusions. Maybe we should, you know, look a little bit deeper into what's going on. And, you know, these aren't meant to shame anybody. These aren't meant to say, you know, you're wrong, you're doing something bad. It just means we might want to take a second look as to what's going on, just to give you a sense of where you stand vis-a-vis the rest of the system. Okay, so we've calculated now these OE ratios, and we've presented them for you, and we've given you some sense of the uncertainty in the estimates that we have, taking into account the patient volume at your site. We then take that OE ratio and we use it to calculate an adjusted rate. So this is your rate of transfusion, taking into account the fact that your patient mix might be a little bit different. So on the y-axis here, this is that adjusted rate, that calculated rate of what we should really be saying your rate is, not what it is, but what we really should be saying the rate is, given that you have more or less complex cases that you're seeing. Once again, we've got this issue of different levels of volume. And so we have it on the x-axis, we have the number of procedures that were performed for hospitals. So you can see then, we then also, again, calculate these confidence intervals. On the prior slide, we just had 95%, but we give you 95 and 99% confidence intervals here. And 99% is just a little bit more forgiving, especially given the number of outcomes that we have, you know, for some of the more severe events that can occur. We often have just overall lower rates. They don't happen as much. So we want to be a little bit more forgiving in our calculations, because the data just aren't as clear. So the 99% confidence interval is really what you should be looking at here. And then you look at your adjusted rate and where it stands within those confidence intervals. If you're within the confidence intervals, within those limits, you're doing fine. You're within the typical variability we would expect given your patient mix and given your patient volume. But when we see values that are outside of those confidence limits, that suggests either your site seems to be doing really well if you're towards the bottom, or again, if you're above the bar, then that suggests that something might be going on, and you might want to take a closer look at how you're working with patients post-operatively. This graph right here, I think it's probably the most confusing to interpret. The big thing is to look at where you fall within these confidence intervals. And if you are above it, that's a reason for concern. And if you're below it, then that's, I guess, a reason to pat yourself on the back. What I have done here is just to give you a sense as to how things change in terms of what we say the transfusion rates are for adjusted versus unadjusted. Right here, as you're seeing this animation now, or as it was just starting, that was the same rank ordering of the transfusions when I presented the very first slide. So this is not adjusting for anything. But after we adjust, then we calculate that new adjusted rate of transfusions, and the ranking of these hospitals changes rather dramatically. And I think that what's particularly interesting, I'm just going to pause until it comes back to the starting version. All right, third from the right, that was the hospital that had the complicated patients with very low volume, and we had that site performing as the third worst when we just looked at the raw numbers. But once we adjust, then it starts looking a lot more average. There's maybe some room for improvement, but the situation isn't nearly as it doesn't look as bad as it did when we were just looking at the raw numbers. So risk adjustment is a really important step that we can take to help give you a fairer portrait of where your specific site stands in reference to the other hospitals that are in the consortium. So that's the presentation. I'm happy to answer any questions you might have.
Thank you, Jeremy. Yeah, I liked your breakdown about confidence intervals, and I didn't know what O and E meant until today, so that's good. Yes, I think this is very helpful for when we look at our 3-year reports. Especially the risk models in the back. Does anyone have any questions for Jeremy? Kimberly Neubauer says, was a hospital with only 4 patients a real hospital or a fake one?
I'm not going to comment.
No comments.
But I did select a different period of time than we usually use, just to illustrate things and to try to keep things a little bit more ambiguous as to what the sites were. But it comes from real data.
Okay, real data, just a different time period.